to a live chat with Nurse Linda. Nurse Linda is Nurse Linda is a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher and Dana Reeve Foundation for close to 2 decades. Just 2 quick notes before we start. At the bottom of your Zoom webinar screen, you'll see the option for closed captioning. You can turn that on if you would like. You will also see a Q&A box, which is where you can place any questions that you may have for Linda throughout the webinar. Now I'm going to turn it over to Linda. Hi, Linda.
Hi, and hello, everyone, and welcome to my home. This is the first time I think you've been able to see me, so this is kind of an exciting day for me. And I hope that you enjoy the visuals, so we'll see how that goes. There's lots of good news, lots of good things to share this month. It's just been an explosion of good things that I've heard, which is kind of nice in this time of COVID because it just seems like it's, really weighing us down. But we did have the Association of Spinal Cord Injury Professionals conference this month, which was very interesting because you get to hear the latest and the greatest of what's going on in the world of spinal cord injury research and with all kinds of health professionals. I did it from my couch because everything is virtual, which is still a lovely conference, and it had a lot of exciting things. I'll be writing about some of it on the blog in the next couple of weeks, so you can get up-to-date information about what's new and going on in that area. Unfortunately, because we never left our homes, I never got to see the conference buddies that I meet up with every year. And I really enjoy seeing those people. I can talk to them anytime, but at conferences where people from across the country really connect. So I was sorry to miss my colleagues. On the other hand, I did make a new conference buddy, Sunny, and I know you're listening, so hello. It's nice to have you here today, as it is nice to have everyone with us today. So there is particular good news on the front of ALS. And I know some people will be thinking, well, I don't have ALS, so, why am I interested in that? But this is the reason. So you'll recall years ago, they had the ice bucket challenge where people were dumping big buckets of ice water over their head, and then they would give a donation to the ALS society for research, and they raised over $200 million, if you can imagine that. So what their purpose was in using that money was to do research, but another purpose was to get people interested in research of ALS. Because it's such a rare thing, there was not a lot of money that was given to ALS research. And it comes down to a matter of practicality. If you're a research and you're not going to be able to get any grant money, you're not going to be able to do any research, you're not going to be able to earn a living. So one of their big goals was to increase the number of people that are interested in performing ALS research, and they have accomplished that goals. They've come up with several treatments that's very helpful, and so great, because ALS is a disease that really needs some attention. It also has the consequence of spinal cord injury, which a lot of times people don't think when they have a medical cause of spinal cord injury, they don't stop and think, well, I have a spinal cord injury. They really identify with the disease. And so either way, it doesn't matter. We're all in this together and we're all working on it together. So one of the things that they came up with is this new drug. It's called AMX0035. So why are we all interested in this drug? Well, I was reading about what it does. And in ALS, one of the problems that people who get ALS in the mitochondria in the cells, every cell has a mitochondria body in it. And those are the powerhouses of the cells. They supply energy to each cell. Sometimes that gets out of sync with a quality control mechanism, and they think that that has something to do with the source of ALS as a problem. So I'm reading this and I'm thinking, golly, if you can stop these nerves from destroying themselves, then why could you not do that in spinal cord injury as well? Because if you can affect a nerve from any disease or accident, you can translate that to other diseases. And by golly, when I looked at the manufacturers, the pharmaceutical company that's working on this drug, when I look at their website, what do I find? But they have a whole list of neurological diseases that they think that might be of some help. And so they'll start expanding the use of this drug. So if you're interested in that, on September 23rd in the Nurse Linda blog, there is a link to the site of that pharmaceutical company if you're interested in finding out more about this. There will be some drug trials of this particular drug with individuals in spinal cord injury. Now, think carefully about if you want to participate in a drug trial, but that certainly is up to you. If you can't find the blog, or you just, well, that's a lot of work to go find that or whatever, just look up AMX 0035. Just Google that and you'll be taken to the websites. That's pretty easy. AMX 0035 is the name of the drug. It doesn't have a brand name yet. It just has this chemical name to it. So what they're doing, why this is so important in ALS, is we know that when people have any kind of injury, say you get a finger cut, paper cut on your finger, and you look at that and you think, gee, it's red and it's swollen and it's warm. That's because a lot of blood is being sent to that area in response to some kind of trauma. And so a lot of nutrients are being sent there, a lot of fluid to help cushion that sore so it doesn't get more damage to it. Natural antibodies are being sent there, white blood cells to fight infections being sent there. And so you might look at your finger and you might say, oh, red, swollen, it must be, it's inflamed. And that's the natural body's response. But what people don't think about is after internal injury, you also get inflammation. So in the nervous system, you can get neuroinflammation. And what happens, because the nervous system, the central nervous system, the brain and the spinal cord, is a little bit unique because the brain is housed in this rigid skull and it will not expand. So if there's trauma in the brain, that same process happens the way the body tries to heal itself. A lot more fluid is sent there, a lot more blood is sent to the site of the injury. But unlike the skin that's got a lot of elasticity to it, the skull is rigid and it is not going to expand. So when you get extra fluid in the brain or in the spinal cord, the bones are not going to expand. So the neural system has this kind of weird little thing that it does, and it's something called apoptosis, which means programmed cell death. So since there's no extra room for this fluid to be in the brain, or in the spinal cord, you have all those bones down your vertebral column, they won't expand either. So if there's trauma to the brain or the spinal cord, there's not going to be this expansion in these bones. So the only place for this extra fluid to take up space is to push up against healthy nervous tissue, which causes this apoptosis to happen, which is this programmed cell death. So some cells, some nerve cells will sacrifice themselves to make more room so that other nerve cells can live. So part of this is this neuroinflammation, and this is what this drug helps control. So if this drug could be used in spinal cord injury, the question is, will it control inflammation at the time of injury, or will it control people who have chronic inflammation? So there's a lot of questions still about it. The part of the spinal cord injury part is still yet to be answered, but it's a step in the right direction. It's a step on the right path. So it's kind of an exciting news. Now, something unique about this is that this is drug studies happen in phases. Phase 1 means that somebody has discovered something in the laboratory and they're just going to test it in humans for safety. So sometimes people who have spinal cord injury, they'll hear about a phase 1 trial, drug trial, or therapy trial. All of these go through these 3 phases. There are sub-phases beneath each phase, but it's basically 3 phases. So sometimes people will say, I have a spinal cord injury. Gee, there's no treatment for this. Here's a possible treatment. I'm going to get involved in a phase 1 trial. And that's great because it's very helpful. But phase 1, you have to realize, is that this is only to check for safety in humans. It's right out of the laboratory and it's going into humans. So you have to think about if you're willing to take that risk, because it could be unsafe. sometimes people will have the idea that really it's a secret trial and it's a phase 1, but they're really going to give me the cure and I'm going to have the big miracle, which of course we would all hope for, but that's not what a phase 1 trial is going to do, because you're just going to get a little bit of the drug to see if it's going to work. Now, if it all works out, and that's just in a small number of people. I've been involved with phase 1 trials when they've done it with one person, when they've done it with 3 people. Sometimes maybe they'll go as high as 12 or 20 people, but they're very, very small trials. Phase 2 is where you get larger numbers, maybe into the hundreds, sometimes even into the low thousands, maybe 1,000, 2,000 people. That's pretty big phase 2 study, but you do get those. And phase 2 is where they start looking at the dosing. So they'll look at a dose, will this little bit work? Will a lot do better? And some people will get the placebo, meaning no drug. And nobody knows who's involved in the giving of the drug, who's getting what, because it has to be blinded, because you don't want to be like, oh, well, I know Nurse Linda has gotten this the trial drug, so I'm going to look at her differently than this person that I know got the placebo. So when you're in those trials, sometimes people will say, can you give me a hint if I got the drug? They don't know. It all comes from the manufacturer. And they never see the patient. So there's no link to know who got it and who didn't until it's over and you're assigned a number. And then, they look at those numbers and see who got it and who didn't. So this AMX 0035 for ALS is going to start given out at the phase 2 level. Now that's a little loophole in drug studies. Loopholes probably has a negative connotation, and I don't mean it to be sounding negative, but it is a little loophole in these kind of studies, because it's a humanitarian use. So if you have something like ALS, we know that that's a disease that does not have a positive outcome. And we know that people who have ALS have a lot of issues and concerns that continue to mount and get worse over time. Since there is no other opportunity for anything else to help relieve some of the discomfort and trials and tribulations, and this AMX 0035 seems to help in that way. It seems to really improve the quality of life and maybe extend life a little bit longer, and not only extended, but you have a little bit better quality of life. So as a humanitarian effort, they are going to allow people, because it's done so well in phase 2, to start getting this drug. Now, how that's all going to work out, I don't know the details. Will everybody be able to get it? Probably not. There'll probably be some kind of criteria for who gets it and who doesn't. So all these things are things that we just have to follow along. But on the other hand, I'm sorry, my phone's ringing, but it'll stop after 2 more rings. The other thing that we have to look at is then the phase 3 study. That's the final level before they go to market. This is where they will give the drug to hundreds of thousands of people, maybe at least tens of thousands. Anyway, they'll give it to a lot of people. There's not tens of thousands of people who have ALS, so they won't give it to that many. But this is the big study right before they go to market. They know what the dosing is. They give it to a lot of people and see if there are any adverse effects, or how many adverse effects, or what the adverse effects are. Now, another thing why that's important is that in the COVID, which is the topic for today, but in the COVID trials, there's a lot of information out there about the vaccine, treatments, and all this kind of stuff. And it's kind of hard to weed through all of this. So I know of at least 52 companies that are working on a COVID vaccine and or treatment. That's a lot of companies. Why are so many people working on this? Because whoever comes up with a treatment or a cure or some kind of help is going to make a lot of money. Now, I would like to say it's all for the benefit of mankind, and I'm sure that there are people in their heart of hearts, that's what they're thinking. But in reality, you have to follow the money. So there are 5 companies that are in the phase 2 clinical trials. There is some talk that on some of these treatments or some of these vaccines, some of the different things that they're trying, there is some talk that at the phase 2 level, some of these treatments will be released to those people who are acutely ill, who are in the hospital, who are ventilatory dependent, who probably death is probably going to be the next step. And so as a humanitarian effort, they will probably give the drug to some of those, depending on how these phase 2 trials go. So just so you know, when you hear on the TV and they're talking about rushing these drugs through and trying all these things, yes, they are rushing the drugs, but there are scientists who are working on these. It's not just like, well, we think this is kind of okay, so we're going to give it out to you. No, scientists do not do that. The CDC and the FDA have a completely rigid rules. But if they have something like this AMX 0035 and they have a treatment for COVID and they're thinking, well, it's working out pretty good for a lot of people, what if we gave it to the sickest of the sickest people because they have no other option? That is how these drugs kind of get through in the quick and hasty. So just so you kind of know that thing. Now, there's another point that I wanted to bring up about COVID, and that is that even with a spinal cord injury, I want you to know that it is possible to survive. You can get COVID. You might not even go to the hospital. You know, we don't know enough about the COVID to know, but it's such a doom and gloom, and we're always talking about people that are at high risk, and oh my gosh, if you get it, it's going to be so horrible. Some people with spinal cord injury get it, and no matter if you have a spinal cord injury or if you don't, let me tell you, the COVID is horrible. People make it out. Some people say, oh, it's like I had a bad cold and after a few days. No, it's horrible. And my personal assessment from what little I know about it is it sounds like if you have it, you might, not necessarily positively, but you might have some lifelong problems from having the COVID. It scars your lungs. It doesn't just stay in your lungs, it travels throughout your body. So we really want to keep ourselves safe from having the COVID. So I brought some things. Duke University did a study, and I know we all know what we're supposed to do. We all know the rules and regulations about keeping so many feet and 6 feet away from other people. If some people are singing or yelling or cheering or whatever, where they're using more breath support, you want to stay even further back, maybe even up to 12 feet, maybe even further. But hand washing, we all know that that's critically important, and also wearing masks. So Duke University did a study about masks and which masks are better than other masks. And so they did this study and they tried different kinds of masks. And so I brought a few today as show and tells, just so we could talk a little bit about them, because I see a lot of people on the news and it just drives me insane when they don't have their mask on properly. Reporters, people who should know about these kind of things. And I think, come on, don't be that example. So Duke did a study and they found the N95 mask, which I do not have here with me today. You can't get an N95 because those are being saved for the healthcare professionals and the people that are working one-on-one with people who are really sick with this disease, to keep those people safe. And that is the best mask to have. They're difficult to wear. They're hard to wear. Some of them have to be fitted uniquely to you. They have to have such a tight seal around here. You'll see people with healthcare professionals with actual scars where their face has been cut from this tight seal. So we're talking serious business. Some N95 masks you have to be measured for, so particularly for your face. So there's a lot to that, and it seems like that's a reasonable thing. Now, shockingly, there are other masks that work pretty well and very effectively, like still in the 99th percentile, according to this Duke study. One of them is this mask, and I brought this one. I'm going to hold it up. I don't know if you can see. It's a KN95. I got this just off Amazon, and it was advertised as an N95. So I thought, well, hey, I'm getting that. And when it came, it had this little K in front of it. I'm like, well, what is that? So this is not an N95, it's a KN95, so buyer beware, because it was sold to me as something different. But it's still, and that's not saying anything about Amazon. It's the person who posted the information. So I've not given that away, who the manufacturer is. But anyway, I love this mask because it fits my face so well. That's one thing about it. And I feel very secure with it. You can see it's got the little bendy spot up here at the top. And it's a mask that covers your nose and it goes under your chin. So it's formed in the right way. It's made of this pressed fiber, which seems to be a little bit better, according to that Duke study. The pressed fiber masks were a little bit better than the cloth mask. However, I do want to point out the little bit better was like tenths of a point. So it's, we're not talking about, a vast amount of difference. So you can feel comfortable if you have a paper cloth face mask. Those are just as well. But these fit over the ears. The devil is in the details. So I just want to point out that when you put on one of these, this already has the little metal piece is already folded, but you do need to mold it to your face. And I hope you can hear me okay. So you do need to press that to make sure this is secure, because you have this hollow around your nose. So the mask really needs to fit secure. Now, if you get a mask, there's some that have a different cut to them that are kind of arched that way and fit without the little metal piece. And as long as you have no openings in here, then you'll be good with that. So you want to put the mask on, be sure it goes over your nose and under your chin to keep everything. Now, I see people on the news and they're talking. And if you talk a lot, guess what? The mask slips down. Your mask is probably too big if that is happening, if it's slipping down. I see people all the time on the news, they're covering their mouth, but not their nose. Well, you might as well not even have one on. If you have your nose or your mouth exposed, you have just as equal an opportunity for that COVID to get in there. I'll also see people with their mask hanging over here to the side. And that's handy because, if you have to zip it up or take it off, it's very handy. But look what's happening. The outside of your mask, where those COVID virus could collect, is here right by your mouth. So you have a higher risk of getting it into your mouth or your nose. Some people like to wear their mask when they're talking and they're socially distant, and you'll see them on TV and they're wearing the mask down here. Again, look where it is. At least it's underneath your chin, so you have a little bit of an barrier between your mouth and where the mask is. However, it's right here by your face. So if you need to take off your mask because you want to talk, unloop it at both ears and pull it down away from your face. If you snap it off at one ear, you're shaking it up and letting those COVID germs out freely flying around in the air. So just some little, it's always the devil in the details. Now, if you have breathing problems or if you have difficulty using your hands, you probably should not wear a mask, because what happens is that if your mask is on and it's snugly fitting around your face, what can happen is that your carbon dioxide can build up inside your mask and you can be rebreathing that. Now you'll notice this mask has a little bit of space in here. So if you're one of those people that don't like the smell of the manufactured mask, I'm one of those people. They stink. They just smell like ugh. So if you don't like that smell, this gives a little bit of breathing room in there because you have that little bit of space in there. Now, the mask does not keep you from getting the COVID. It prevents you from giving the COVID. So if for some reason you can't breathe well, or you have a breathing issue, or you don't have good hand function, just stay socially distant. My theory is if you've got something covering your face, it should help a little bit. Maybe a COVID, won't make its way in there, but these are the official rules. So I think it's good, but we have to think about all these different little details. This is the hospital surgical mask, which is a wonderful thing. It's again, this pressed paper. So there's not really the weave and holes through it. It's kind of just this pressed paper. There's still some holes in it. The way you check your mask to make sure if it's effective is you put it on and try to blow out a candle. If you can blow out the candle, the mask is not effective. So just so you know, that's a little test you can do. This is a regular hospital mask, and it has the little plastic thing up here. If your mask has these vents, be sure that the vents are going down. If you wear the mask upside down or inside out, the vents are there collecting COVID bacteria to live inside your mask. This way they can roll off. Again, it's the same thing to make sure this is sealed around your nose and put it on. Now, this is a brand new mask, and you'll notice that, look at the difference where my index fingers are. See, one is so much higher than the other. This mask came where this ear loop is much bigger than this ear loop. So I got one mask that was a manufactured mask like this, and the elastic in this ear loop was completely stretched out. So it was just hanging there. It was just not doing anything. Be sure that the mask fits your face properly. If you have an ear loop that is too big for you and your mask won't fit securely, you can make a little tie in it and make it shorter, or you can put a little clip in it. Be sure you put it down at the bottom so that you don't have it not rubbing up against the back of your ear. Now, this is a cloth mask, and I purchased this, and I was very excited about this. It's nice and thick. It has some kind of padding on the inside of it, and it mimics a surgical mask. So I thought, well, this is right up my alley. I like this. So this was one of the first ones that I bought, and it was really nice. But when I got the package of 10, the first thing I did was put it in the washer, and I put it in the dryer, and guess what happened? It shrunk a lot. So be careful when you buy these manufacturers. 100% cotton, which at the time they were saying that's the best of the best, which is why I got it, but it shrunk a lot. If you want to be really careful with your cotton mask or fabric mask, you can just take the iron and put it right on there. You need to wash and do that, but you need to, if you want to iron them, that helps kill some bacteria and viruses on them, as well as washing them. Anyway, I got this mask, and when you notice when I put it on, it's tight because it shrunk, and it's really hard to get a good fit. And if you can see my mouth talking through it, you know it's way too tight. So now I've already got my investment in these. What am I going to do? Well, eventually I'm going to cut these little loops and make the loops bigger, because it does have a nice fit to it, but it's just too tight for my big old noggin up here on my head. So kind of interesting kind of things. Now, if I would wear this mask that's too small for me and I would wear it places, I find that it pulls on my ears and it gets very uncomfortable. We have a name for that. It's called ear fatigue. Can you believe it? I have ear fatigue when I wear those. My mask gets very, makes my ears tired. The hand sanitizer, this one I have, it's, well, this one is 70%, but I bought a bottle of no-name hand sanitizer that was only 60%. You need to have that alcohol, 60% alcohol. You need to have that alcohol in there. That's what kills the germs. Put a little on your hands. Rub them, rub in between the fingers. Be sure and get your thumbs. Be sure and get your fingertips if you touched anything. Just like you're washing the hands, wash off sides, go on up to your wrists. The hand sanitizer is not ready. It's not sterilized or cleaned your hands until it's dry. So keep going with your motion. I find the 60% took a lot longer to dry because it had more liquid than alcohol. Alcohol tends to evaporate quickly with friction. So the higher the alcohol content, the better. Also, this is some hand soap. one of the things that I have found is this is an antibacterial hand soap. It has a lemon scent to it. Now, if you have kids or if you're just a person like me, I can't wait to wash my hands because I love the smell of this. And so it's just like a real treat. Something else that I have discovered are these little gloves that people use in the food service industry. They're not airtight, but I find that if I go to the store and I don't have spleen function, so I'm immunocompromised too, so I'm very careful about what I do. But I find if I wear these to the store or if I'm going someplace like to the doctors that I have to use a lot of pressing the elevator or use my elbow or opening doors, or I might be touching something that I don't want to be touching, I find that these are very handy. I do not, and they're cheaper than the hospital type healthcare gloves. I do not think they would be strong enough for propelling your wheelchair. I think they would break apart. But anyway, depending on what your activity is, that's something. Make your hands sweat a lot. I also, don't forget your wipes to wipe down your wheelchair. Yes, I have this. Oh my gosh, my prize. It's so hard to get a hold of. So anyway, just some thoughts. I hope I haven't left anything out, but anyway, the devil's in the details. So in the hand sanitizer, I was in the car the other day, the steering wheel's here, put the hand sanitizer and I'm rubbing it into my hand like I do, lotion. Where are your hands when you're doing your hand sanitizer, loosening those COVID viruses on your hands? Oh, we do it up here, right by our nose and mouth. Force a habit. So I'm trying to change my habit, so I'm doing that down by my waist now. These are the little things that, just little minor modifications, but, they could help. So thank you for listening to that. Let's go on to some of the questions. And I see there's a question with on the blog here about our patients. Absolutely. Spinal stroke is more common than people know. People know about strokes in the brain, and but they don't know that a stroke can happen anywhere in the central nervous system, which includes the spinal cord. So 80% of strokes in the brain are from a blood clot. Now, you can get a stroke from a blood clot or an embolism in the spine as well. If you go within 4 to 6 hours to an emergency facility, there is a drug that thins your blood. They give it to you by IV and will help dissolve the stroke. And a lot of people who have these thrombosis type of strokes, 80% of people that have strokes in the brain, we don't have the number for in the spine if it's the same, but we operate under the assumption that it's close. So if you get to the hospital in time, a lot of people have very little, if any, residual from their strokes. And it used to be when I started out in rehabilitation, my goodness, we'd have a whole wing full of people who had strokes from any source. And, that was the bread and butter of the rehabilitation world, was strokes, the number one. Now you go to a rehabilitation facility, you rarely see people with strokes because they go and they get this clot buster, and so they have very little residual. And if they have to go to the rehabilitation hospital, it's for a very short amount of time. Now that leaves the other 20%, and how do they get their stroke? Well, that's from a bleed. So some vessel has ruptured. And there again, it's that extra blood that's in the spinal cord, but the cord's in this rigid vertebrae, and so the spinal cord can't expand. So that blood's taking up space, which is going to push on the nerves, which is going to set off this neuroinflammation and the apoptosis. And so that's what happens. So in the ending result, if you have a spinal stroke, or if you have injury from another disease, or if you have it from trauma, the result is going to be the same. You have the spinal cord injury. And so whatever level that's going to be. Now, do people recover differently after spinal cord hemorrhagic stroke? So those from a blood clot. Well, that depends on how big the clot was, how long the clot was there before it was dissipated or resolved through surgery, if surgery was possible. So there's a lot of different events that can change the course of that spinal cord stroke. So we have to remember in all spinal cord injury that the nervous system wants to repair itself. It wants to figure out different ways. If it can't get through one nerve, it's going to try to get a message through other nerves. So the more movement you can provide to the spinal cord injury below the level of injury, the more input you have to your body that's sending messages up, while at the same time thinking, somebody's moving my leg or moving my knee or moving my toe, and thinking about that message, move toe, and send that message down while the toe's moving, while the message is going up. And we do see people that have recovery from spinal cord injury. Now, this was the way it used to be, is that they used to say, if you haven't had recovery after 2 years, that's where you're going to be. We know that not to be true. Why did they say 2 years? Because that's as long as they looked for it. They didn't look for people into 10 or more years. They didn't even look at 3 years and see what the recovery rate was. But just about everybody gets something just naturally. Maybe it's a little finger movement, maybe it's a toe wiggle. There are all kinds of things that happen just kind of serendipitously, and people get recovery. So what we need to do is keep harnessing that. Now, it would be lovely if everybody could have more and more therapy, but we know that that is not a reality. So we have to deal in what is reality. So we have to think about these things. So if you have a caregiver, if you have a family member who can do range of motion exercises, if you can do range of motion yourself, you're providing that input into your body below the level of your spinal cord injury. We know that the body loves to have activity. It's just that one spot in the spinal cord where those messages are not being sent between the upper body and the low and below the level of the spinal cord. It's just that one spot. Your body still works magnificently below the level of the spinal cord injury. It's just not getting the message from the brain to make it happen. So we have to provide that, and the more activity that we can provide to the body, it seems like the better people do. So that is something that more and more research is being conducted and being shown that that is happening. Now, there are advanced therapies that you can get involved in. They are often not paid for by insurance. Some are not, but these are the kinds of things, that, the reality in which we live. And in my world, people would be getting advanced therapies all the time, because we see that these are really benefiting patients, especially those patients who have the ASIA ratings of incomplete are doing a lot better when they have a lot advanced therapies. Now, research is showing this, so why don't insurance companies pay for this? Well, that again is a matter for, I guess, the brainiacs and the bean counters. It's very expensive. And so I think that it's not that people don't want to supply that, but until they get, this is absolutely the proof. Now, in my mind, the proof is there. But some people need, more evidence to say, so it's kind of, it's an unfortunate situation, but we're working to rectify it. And all kinds of things are going on with getting things a little less expensive. And the other thing is that people have to want to do it. And if you look at the general population, people without spinal cord injury, we all know that movement is important for the body, no matter if you have absolutely nothing wrong with you, or if you have other health conditions. What is the very first thing? Movement, exercise. So how many people go to the gym? Not very many. How many people really do their exercise religiously every single day? Oh, there are a few, but still far from the majority. People with spinal cord injury are no different than anybody else. The time and energy and effort to do these things, it's a challenge. So you really have to make that commitment to be dedicated to it. But even if you have no equipment, just doing those range of motion exercises, it gives that feedback below the level of the spinal cord injury, and it just does a lot of things for it. So if you have any more questions about spinal cord stroke, there's also information at the Christopher and Dana Reeve Paralysis Foundation about stroke and spinal cord injury stroke. It's being updated as we speak. So I'm not sure if the new information is posted up there, but the new information does have a lot of, the new web page does have a lot of information about spinal cord stroke. It's mostly treated just like spinal cord injury. It's just that the mechanism of onset is somewhat different. There's another good question that came in, and I apologize for looking over here to the side. This is where I can read the questions, because now my screen has my picture on there. So I like that my picture's up there. I think that's very helpful. Makes things a little more interesting than just listening, although I don't know that looking at my mug is going to make your day. But anyway, I kind of like it. I wish I could see you too. But anyway, so this is a great question. What is the best way to handle the prep for a colonoscopy? Oh, wow. What a question. Because the prep for a colonoscopy, any way you dice it, is not pleasant for anybody. When you have a spinal cord injury and you have issues with bowel control, and you're taking this medicine that's going to give you this kind of horrific diarrhea, any which way you turn it, it can be tricky. So there are some things that you can do. Now, first of all, call your insurance company, look at the number on the back of the card, see if you have an insurance case manager. That's a person that you want to get to know through, and if you have Medicaid, look at the number on the back of your card, ask for a case manager from the insurance company. They can help you navigate the financial world of that particular policy that you have, no matter what it is. There are some people who are having a great deal of success of getting admitted to the hospital the night prior to their colonoscopy, simply because the prep is such an ordeal, and especially trying to do it at home, especially if you're alone, because it's going to give you diarrhea. There's no way that you should ever just sit on the toilet that long. Or the commode, you're going to get a pressure breakdown. So if you can talk to your insurance case manager, there are some people who are getting admitted. It's a lot easier to have a full staff that's there ready to help you through this process than you and maybe whoever's helping you at home to try to do this, because you have to drink the solution, you have to maybe take different pills. Some people have to have enemas. Each person who does the colonoscopy has kind of a little different routine. Now, I will tell you, if you have to drink the calcitrate, I think that's what it is, calcitrate. If you have to drink that, if you refrigerate it, it's a lot easier to go down than if you just drink it at room temperature. So that's a little tip I have. Also, if you put it in use a straw to take it, and if you don't have swallowing difficulties, if you put that straw kind of at the back of your tongue and don't allow yourself to put it back there that you're choking on it, but put it a little bit past your tongue, you don't get as much as the taste, and that's helpful as well. So some of the things that you can do is, be sure and pad the bed. If you have time to get to the commode, but you don't know when it's going to take effect, this is why we don't recommend enemas and laxatives for people with spinal cord injury, because you don't know when it's going to work. So it's usually easier for people to do this in bed. Be sure and pad the bed so that you can, remove the chucks as quickly as possible. You don't want that stool on your skin very long, because that does a lot of breakdown too. Use wet wipes to do that. to clean up with it, because toilet tissue can get a little bit rough when you're using it. There are some things that help. If you're a man and you have done, you have a catheter and maybe it's giving you a rash on your skin where the external catheter is being held on the penis. Sometimes there's some urine that collects in there and it gives a rash on the penis. So there is a thing called skin prep. You can get it online. You can go to Amazon or Walmart or wherever. It's called skin prep. It's not even a fancy name. It comes like a alcohol pad, and you just tear that open, and it's kind of a sticky stuff. Now, for the rectal area, you might need to use a couple of skin preps, but you can wipe that around the area, and it gives a layer of protection of the skin. Some people will use a heavy emollient lotion so that that caustic liquid stool doesn't burn the skin quite so bad. You could put it right on the rectal area as well, as kind of to protect that. Some people will use Vaseline. It's a mess to clean up at the end, but it really is thick enough to keep that caustic material off your skin. So those are just a few of the things that you can do. Oh, there is one other thing. There's something that's called a rectal bag, and sometimes people who have a lot of gas or they're worried about having an accident in public, it's not something you should wear all the time 24/7, but it's kind of like this little plastic bag that has some adhesive, and you can put it around the rectal opening, and then the stool gets collected in this bag. Some people wear it just if they have a lot of gas for some particular reason. Again, it's not the kind of thing you want to wear all the time, because air is not getting to the rectal area. The stool is going to be pushing up against that, and that's a recipe for disaster. But if you're getting ready for your colostomy, you might get an extra large rectal bag that can contain this, but you'll need to change it in between, periods when the stool is coming out. So you can't just wear it and be done with it. Sometimes the smaller ones will blow off, so you need to get an extra large one, because when you're doing the prep for a colonoscopy, there's a lot of stool involved there. You can try it. You may not like it. They're expensive. There's all kinds of and this and that, but you can try that, and that will help from getting the stool all over the bed or whatever. You can wear those sitting up, but usually in the explosiveness of colonoscopy prep, those black bags can blow off, or it just doesn't stay on with that kind of pressure. But some people find that it works out okay, so it's just another thought. But talk to your insurance health case manager, and perhaps they might even admit you into the hospital to have this procedure, the prep. So good luck on that one, because that's hard for everybody. So here's the next question: is that a spouse is obtaining caregiver status because of the COVID, and they're sheltering in place, and let's see if I can scroll over here and see what the rest of this is. So they're having lots of issues going on. So I'm not quite sure what the question is. But anyway, lots of high risk factors with this person. So continue to shelter in place, continue to use all of your techniques for cleaning. This is not the time that we should be going out. When the COVID first started and we were watching the tracking of the cases on TV, and oh my gosh, it was so horrible and all this and that. Now we have like 3 times the viral load out in the community, and people are like, well, why can't we have childhood sports? And why can't we go back to school? And why can't we do all these things? And the viral load in the community is a lot more than it was at the beginning. So, this is the time to be extra super cautious. These are really, these are dangerous times for us all. Now, the next question is that they're looking for a few tips on best exercises to gain strength to transfer independently. Well, getting the arms in shape and getting the muscles up in the shoulders is particularly important because your shoulders aren't really created to carry the weight of your body like your hips are. But when you're using your arms and your shoulders to raise yourself up, you really need to have strong arms and strong shoulders. So you can get a twofer by doing some wheelchair push-ups, pushing up on your wheelchair and holding yourself up and trying to extend that time that you can hold your body up. So you need to get your arms, if you get some arm weights and strengthen your arms, you also need to strengthen your chest muscles and your back muscles, and looking at all those muscles around in the shoulders to get strong. Now we have pulling muscles, so we have the way our muscles work this way, and then we also have counterbalances, so we have pushing muscles. So the pulling muscles are usually a little bit stronger than the pushing muscles. So you want to be sure that when you exercise that you work both the pushing muscles and the pulling muscles. So it's hard to push our arms up, but it's easy because gravity helps us to pull our arms down. So you might want to work just a tad more on those muscles to be able to pull up. Gravity is going to help, but still you want to strengthen under your arms as well. Also think about strengthening your hands if you can get some grip strength, because there's going to be a lot of pressure put on your hands because, again, the body weight, that pressure is going to be mostly there. So go as low as the muscles as you have muscles that are functioning, but try to get the biggest bang for your buck. If you're doing your wheelchair push-ups in the rehabilitation setting, what they usually have you do is sit on the mat, and they have some little hand devices that are just wooden blocks, and you're pushing yourself up, trying to get that strength built up. And so that's usually the way that things get done. But any upper body exercise is going to help you with getting that strength to transfer independently. And a lot of people can transfer pretty well. Use adaptive equipment if needed. Some people who have higher injuries maybe aren't not going to be able to completely lift their body. They might be able to lift it somewhat, but think about a sliding board. If that will help you transfer and you really want to transfer independently, that's a good start. Use your adaptive equipment. If you have a really high level injury, you might want to see about talking with your insurance company about one of those lifts for the ceiling that you can use by remote control to kind of zoom around the house. You can go from your bed to the bathroom, to the toilet, to the shower, and back into your wheelchair. So those are, again, high ticket price items, but if your case can be presented to the insurance company, go ahead and ask your healthcare professional for a letter of medical necessity. Now, if you decide to do that with your healthcare professional, remember that the answer is not going to go to the healthcare professional. The answer is going to go to the owner of the policy. So the healthcare professional will be going along, and they might not ever know the answer, but you might get a letter in the mail, or whoever owns your policy is going to get the letter. And on the first pass, for very high ticket items, always know the answer is going to be no. So don't be surprised. The answer is going to be no. And then you'll need to renegotiate and have your healthcare professional send another letter with more reasoning. And you might have to go through this through several iterations. I was just talking to a man that took him, I think, like 2 years to get some equipment that he wanted, but he never gave up. But as soon as you get that letter, if it's a letter of acceptance, well, good, then you give it to your doctor so they can order the equipment. If it's a letter that says, no, you can't have this equipment, give it to your doctor right away, because they only have a certain window of time to respond. And so, every day that you're holding on to that letter and not giving it to your doctor, that's a little more time that's eaten away in the process. So it's kind of around goes, but you can see it's the one who's paying the money on the policy is the one who's going to get the answer. That's the one who's owning the policy. That's why it's a good idea to know your insurance case manager and have a really good relationship with that person, because they can advocate on your behalf. Now, they will look at your policy and they will say, oh, your policy does not cover this. But if you say, well, you know, it's for mobility training, like if you want one of these lifts or something for mobility training, well, you know, mobility training might be covered. So, you know, have your healthcare professional word it and work with that insurance case manager. That's going to be very important. The next question is about a person who has a son with a traumatic brain injury and a spinal cord injury at T3, T4 for 18 years. He now has a tracheostomy and has lots of trouble for breathing. So she wants to know the life expectancy. And I will tell you, people who have spinal cord injury have the same life expectancy as people who don't have spinal cord injury. If you have a higher level injury where there's breathing problems, that's when you get into a little bit of delayed. Spinal cord injury is not something that necessarily is the source of your demise. It's the complications of spinal cord injury. Now, I know that's splitting hairs, but things like pneumonia, things like urinary tract infection, pressure injuries, those are the things that tend to claim people's lives. It's not the spinal cord injury itself. So it's a little nuance, but it's an important nuance. So she's looking for some something to help him with his breathing. And he's talking, he's driving his wheelchair. So it will be best if you talk to your healthcare professional and get a respiratory therapy consult, especially since he has the tracheostomy, to find out what his level of abilities are that can help him with breathing. Now, there are things that people can do, and it's going to be important with the trach. It's important if you have a spinal cord injury, no matter at what level, because you need, there are several muscle groups that help with breathing, even muscles in the neck. But the three big muscles for breathing, of course, are the diaphragm, and then there's some little bitty muscles in between each rib that make your ribs go out this way. The diaphragm pulls it down. The interesting thing about the diaphragm is it just relaxes and the air pushes out. There's not a muscle that forces your air out. You can force your air out by making a conscious decision to make a forceful breathe out breathing, forceful in breathing. But the diaphragm really just pulls down so the air comes in, and when it relaxes, the air automatically goes out. And then the third group are the abdominal muscles. So even if you have a very low spinal cord injury, that can affect your abdominal muscles. So everybody needs to periodically throughout the day take some deep, deep breaths. And if you do 3 really deep breaths, that usually stimulates a cough. If you don't get that cough stimulation, keep practicing. And so 3 deep breaths in and out, and then that stimulates a cough, and try to give the best cough, because that moves things around in your lungs. So that is the basic exercise for anybody with a spinal cord injury. Now, there might be more things that will be able to be done for your son, but you'll need to get a respiratory consult to see what his abilities are and what should be done. If there is suctioning involved, that can help keep the airway clean as well. Some people don't care for the suctioning so much, and they will try an insufflator, which works by changing the pressure in the lungs. It's a little bit more difficult to get used to. Suctioning is uncomfortable. The insufflator is just kind of scary the first few times you use it. Because it works on pressures, and it's just kind of a different thing, but it's more gentle. So if you can adapt for use, that's, some people like it, and other people never can really kind of get past that feeling when it first happens. So those are some things you can talk again to your healthcare professional, and might need to write a letter of medical necessity for the insufflator if you even want to try it. Is there a group of doctors or educational institution that's on the cutting edge of urology for SCI patients? Yes. Yes, certainly there are academic medical centers. If you go online and look for scholarly papers about urology, spinal cord injury and urology, there will be all kinds of information that will become apparent to you. Now, those are written by medical people with medical jargon, scientific people, and research jargon. So if you go to places like the Christopher and Dana Reeve Paralysis Foundation, it's all translated for you in English. So that is very helpful as well. Oh, there's a question here on the chat box about the use of NMEs for bowel movement. Can it have long-term effects, and is there anything you can do to minimize these side effects? Well, NMEs is kind of nice. It's called the mini enema. That's enema and easy. It's NMEs. It's enema easy. We don't recommend general enemas because they work so far up in the colon, it really flushes out the colon. The colon moves bowel along with little tiny hair fibers called cilia. It moves the stool around, and these little cilia, these little hair fibers and the muscles of the colon are saying, come on down, come on down. It's like that TV show, come on down, stool. So anyway, if you take a regular enema, it goes way high up in the colon. It tends to wash out these little cilia. You have also those little hairs in your ears. If you have too loud of music around you for too long, it tends to, these little hairs that twitch while sound is going by, it tends to wipe out those hairs. Also in your nose, people who pick their nose a lot tend to pull out those hairs while they're doing that. And so it kind of disrupts some of the filtration. So this NMEs is a little tiny enema, and it only works in the very lower part of the bowel. So some people will try that NMEs, and it works a little bit quicker. You still might have to do the digital stimulation to make sure you're empty. If you have a lower motor neuron, it may or may not work for you effectively. So those are kind of some things to think about, but generally people don't have long-term side effects with that. When you first start it, you might have some diarrhea because your bowel's not used to that kind of stimulation, but it's kind of almost the next step. I know there's a question coming up about bowel programs. It's kind of the next step up is to try that. It's something to think about. We start with the suppository and DigStim for people who have higher level injuries. For those lower motor neuron injuries, it's going to be just the DigStim because the suppository is not going to stimulate the bowel as it will in the higher bowel injuries. So it's kind of the next level is that people might try to go for that as something. There's also a question, I'm sorry our time is up already, but there's also a question about the difference between spasticity, spasms, and tone. There is no difference. They're all words for the same thing. Now, a spasm is just one event of spasticity. So when people are talking about that, it's all kinds of interchangeable. Tone is a word that is more medically correct for spasticity. So healthcare people are going to the word tone. You'll see it a lot in different places. For this tightness that this person is having in the chest all the way down to the body, that's probably spasticity or tone. And so some treatment for that would be taking some medication to help relax that. Since it's from the chest on down, if you don't like oral medications, if they're making you too sleepy, you might want to think about a baclofen pump that would just bathe the spinal cord, that would help relax that. That is a higher level treatment. You'll want to try some of the other treatments first to see if you can relax some of that spasticity in the body. People see spasticities in the arms, they see it in the legs, they think, oh, I'm having a spasm, one event of it. A next event would be another spasm. Collectively, it's spasticity. medically correct its tone. It's all the same thing, really, in reality. So, you know, there's ways of working up the chain of treatment. You don't want to start out with the highest level of treatment. You want to keep your body working as normally as possible and then keep going, because eventually, you know, you run out of treatment. So you want to make sure that that lasts. There's also a question in here about a person who's disabled and they're looking for help. So please keep looking at the Reeve website and searching for information, because information is power. So I hope we got some information out today. And I thank you very much for coming. Oh, I'm going to take one more minute because these questions are so good. There's a question about using a flush for a Foley catheter. And so if the catheter gets clogged with sediment or something happens, sometimes you can flush the catheter with some sterile, normal saline to dislodge that kink. You'll want to get education on how to do this if possible. There was a time back in the day when I started, when we used to flush everybody's catheter every night with antibiotic medication. And people still got infections. And the problem was not the flush, the problem was doing the flush, because that was an opportunity to introduce infection when you would open the system to flush the catheter. So people had more infections, they found, with antibiotic flush. Plus, the more you introduce antibiotics into the body, the more resistant you get to them. So people who got more urinary tract infections, and then they were resistant to the antibiotic because they were being flushed with this antibiotic every single day. So it turned out to be the treatment was more harm than doing it. So now we say, if you have a Foley catheter, you can drink fluids and keep the kidneys working and keep urine going and flush out that catheter, and then only take antibiotics the minute an infection appears there, which doesn't add up so much that you're not constantly having these antibiotics. So I'll just leave that as my last bit of trivia for the day. And I thank you very much for coming. I'm sorry we've gone over a little bit, but it's always interesting. Remember that I am online and you can communicate with me directly if I didn't get to your question and you want to know your answer. I'm online on Wednesday nights, so tonight at 7 Central Time, and you can ask on the community, you can ask a question so everybody can see it, or you can put it in a mailbox and just address your question to me if you want to keep it more private. People who have questions that get on the community, it's always amazing. If you have the question, so does about 100 other people. So if you're willing to put it out there for everybody to see, you've helped a bunch of other people as well. So I thank you once again for coming today. And it's just been delightful. I love the Zoom, and we'll take it up again next month. Thanks so much.